हेलो प्रतिभा। हेलो प्रतिभा। प्रतिभा, can you hear me?
Yes, sir, you are audible, sir.
Hi, Pratibha. Pratibha is there. Who is sharing this? Because this needs to be changed. The other one has to be good. Let me just.
Rakesh, my screen is seen? Hello,
It's
Rakesh.
visible, sir. Sir, it's visible.
Yes, sir.
थोड़े बस डॉक्टर सुष्मा और डॉक्टर प्रवीण के एयर्स का थोड़ा डिफरेंस रह गया था. Nothing else. Hello, sir. Dr. Anu has joined. Pratima is there? Sir, Pravi.
हाँ जी सुरेंद्र
हाय सर, कैसे हैं? नमस्कार सर. कितने बजे कट है आप बता दीजिए.
टाइम तो हो गया 7 बजे बोला हुआ ना तो डॉक्टर दिरारी हैं देख रहे हैं हाँ ही देर So I think everybody seems to be there and we have around 160 participants at the moment. Murki Srinivas is joined.
Pratima is silent. I don't know. I'm doing it on behalf of-
मुझे लगता है सुरेंद्र जस्ट 7:05 पे शुरू कर दो 2 मिनट और देर
ठीक है. I can see Dr. Shrestha from Nepal. Um, विधान ये क्या सबको अभी ओपन कर दिया गया है या अभी सिर्फ पैनलिस्ट तो बात कर सकते हैं? Is it open for all?
सर सिर्फ पैनलिस्ट ही बात कर सकते हैं.
अभी ठीक है. तो प्रतिमा है यहाँ पे, डॉक्टर भंडारी, डॉक्टर देवदारी, डॉक्टर अमित उपाध्याय, डॉक्टर राजेश मेहता is joined. नमस्कार सर. डॉक्टर सुषमा नांगिया, मैम is there. नमस्कार मैम. डॉक्टर तेजो, डॉक्टर देवजनी गुप्ता, डॉक्टर कविता is there. Tova is there. Lakshman Shrestha is there. Rakesh from Uttarakhand is there. Ankita Raj is there. Dr. Professor Sanjay Day from Bangladesh is there. Many states have to join. Bijan Dada is there. Faisal has Maldives have joined. Hi Faisal.
Yes, how are you?
Hi, Faisal.
Well,
Good. Ah, you joined long time ago. And because we are not able to, I was not able to follow this. The speaker has joined, Dr. Anu. Faisal, there are 4-5 Faisal. I think many people are joining with your link, Dr. Faisal. 5 people are joining with your link. From Maldives.
I think participants must be there from all this. Yeah.
Virinder, I think let's get going. We have more than 200 participants now. And
Yeah, I think we can move on.
Vidhan, can we just open it for all participants too?
The talkback facility is only for the panelists.
But are they able to see, hear us?
Yeah, they can see.
Oh, I thought you have just blinded them. Okay, they were the opposite. Good afternoon, everybody. Namaskar, Namaste. स्वतंत्रता दिवस, भारत के स्वतंत्रता दिवस की शुभकामनाएं. On this day, as we gather on this occasion of the Independence Day of India, and it's a very momentous day for Southeast Asia region because many countries redeemed their pledges to autonomy, to self-determination on this particular day. Let us take a moment on this day to reflect on the core values that define our mission in the field of newborn care. Our commitment is to these values, all of us. We are committed to these values, and that remains unwavering. And we strive to enhance the health and well-being of our nations and our region's youngest citizens. The National Neurology Forum was founded on the principles of compassion, expertise, and collaboration. We are united by a common goal to provide the highest quality care to newborns and their families. It is essential that we continue to uphold these values as we move forward without any of our personal biases, personal ambitions, personal institutional equations into these things. Our responsibility transcends any of these boundaries, personal gains. It lies in nurturing the future generation by ensuring that every newborn receives the care they deserve. And let us continue to work toward this. And I'm told by Dr. Pratima and Dr. Muki that there are almost like 840 registrations from 21 states and 3 union territories of India and 4 neighboring countries of Southeast Asia region, namely Nepal, Bangladesh, Bhutan, and Maldives. With Bangladesh having the highest number of 75 enrolled from their part. There are around 120 faculties across these states. Each state has around 8 to 10 faculty. Some have more. And there are around 47 mentors, national level mentors, who will be mentoring these things. So, and there, as of now, there are 14 WhatsApp groups which has been done. So with these, I want to invoke Rabindranath Tagore, Mind Without Fear, on this occasion, because that is important. And here I invoke and tell all of you that these words are so important for all of us to learn, where the mind is without fear and the head is held high from all of us, where knowledge is accessible, freely available to all of you, like we are doing right now, where the world has not been broken into fragments by narrow domestic walls. And that is why we are going interstate, inter-region, and inter-country also. And the word come out from the depth of truth. This is evidence-based, where tireless striving stretches its arms towards perfection. All of the mentors are doing that. Since yesterday only, the WhatsApp groups are just filled up with so many questions, with a clear stream of reasons has not lost its way into the dreary desert sand of dead habit, where the mind is led forward by thee into ever-widening thought and action, into that heaven of freedom. My Father, let my country awake. Let my newborns be taken care of. Thank you, sir. With these words, I think I'll request Dr. Praveen Kumar to give the message. I will stop sharing my thing, and sir, you can.
Thank you, Surinder. And good evening, good afternoon, and a very warm welcome to all our people who have joined online today, the participants, the faculty, the mentors, our brothers and sisters from the neighboring countries, and of course, our executive body members of the National Unitology Forum. I think the idea of this kind of program actually started a few years ago when we were working in the state of Madhya Pradesh with doctors and nurses from the special newborn care units of India. When we were trying to improve the quality of care they provide, what we learned, the information is now so easily available. There are several guidelines, textbooks, and the World Wide Web in our hands. Everything is accessible on YouTube and other channels. So there's no dearth of information. However, every place has different, local problems, contextual issues. So how does one apply that knowledge or skills, what you learn in your own environment? So there was a need for quality improvement skills. At the same time, when you read the guidelines or listen to some talk, all of us might interpret things differently. So there's a need for dialogue, discussion, trying to understand what exactly is the meaning. So what we learned that in order to improve the quality of care, we need both. Number one, clarification about the content of care, what we provide. And secondly, the skills of quality improvement. As a result, two packages were born, the preterm package and the point of care quality improvement package, which have been applied all over the country. And subsequently, then for the procedural skills, we started a standalone NEOMAP workshops and several QI workshops. But as happens in any kind of standalone workshop, people come, they listen, go back, and then they struggle to apply that knowledge because what you are taught and what you face is totally different. So that is the whole concept of this program, that we need to use the principles of adult learning and not didactic teaching. And luckily, we have learned during the COVID pandemic the power of this online platforms, the social media platforms, saving resources, time and money. So that's why we thought a hybrid mode, which means an online system hosted on one of the social media channels, and here we are using the WhatsApp channel, combined with face-to-face skill workshops where people learn the skills and spread out over a reasonable duration, not too long, not too small. So that's why the 6 weeks period was chosen up after a lot of discussion and experimentation. We thought this can be a good model to, promote collaborative learning, because in this kind of model, you are able to interact with hundreds of other people across different states, different countries, who may be facing same kind of problems and who may have solved it in their own way. So it's easy to learn from each other or teach each other. So it's, everyone teaches, everyone learns, that kind of system. And our first experiment in 5 states in the earlier half of this year was pretty successful, which encouraged us to expand this program and also offer to the neighboring countries who have similar kind of work environment, similar kind of problems. And as Dr. Bisht said, we have nearly 1,000 people involved in this. I mean, more than 850 participants, and then teachers, facilitators, mentors. And I think this is going to be a great learning experience for all of us. It's going to generate a lot of new ideas, going to help people to change practice, and also undertake a lot of quality improvement projects for which all our mentors and faculty members are ready to handhold and guide you through the whole process and culminate in the successful execution of this. There are so many people who have been in the background working for it, and if I start listing everyone, I think it will take half an hour. But few people I want to highlight. First of all, Dr. Ashok Tiwari, who is a mentor of mentors, our past president as well, and one of the greatest educationists in the country, who always encouraged and has always been embracing newer ideas, newer technology platforms to spread education. And secondly, the NEOQUIP committee, specifically the 2 advisors, Dr. Sushma Nangia and Dr. Srinivas Murki. Srinivas Murki, many of you must be familiar with, always bubbling with energy and always giving positive statements that everything is doable. He has stayed in the background, but he has been the master planner. And then Dr. Pratima, Ira, and Ankita. I think they are the workhorses for this program. And in all the groups you would have seen, they have been so active, ensuring that everyone is receiving the material, and all the mentors are our faculty members are oriented. And there's so many other senior members who have voluntarily agreed to share their wisdom, expertise in the groups and guide everyone. So I think it's a great opportunity for all the participants and for all of us to learn from each other. And this is going to be a unique experience, I can assure you all. And again, luckily, this is a totally self-funded program, funded by the registration fee which people have paid. There's no sponsorship, nothing. And we were able to see in the first phase that this is possible to do. And I'm glad in phase 2 also, this will be possible to do simply from the registration fee paid by the people. But the value you will receive is, I think, several fold than what you've actually paid for. So thank you everyone, and wishing you all a very happy Independence Day. And I pass on the baton to Dr. Surinder for the next proceeding.
Thank you, sir, with these words. And thanks that you welcomed and mentioned the names of people which I forgot to take in my address. I would request Professor Ashok Tiwari, sir, who is our past president and the chairperson of the Education Committee, NNF 2023, to tell us about the role of blended learning in small and secure workload. So.
Thank you, Praveen and Bisht and the entire National Neonatal Forum of India. I think it's a great moment. We are connecting to large number of doctors and nurses who are taking care of newborn babies in their respective setups, not only in India, but in 4 neighboring countries. We are so happy that the e-content which is created is being shared through a blended learning manner to each and every participant. But there is a huge big role of all the facilitators and mentors who are involved in spreading the best practices for newborn babies. Blended learning is a mixture of learning methods that incorporates multiple teaching models, most frequently e-learning and traditional face-to-face learning. We use e-learning in the background, but it is a hybrid mode in which we use even face-to-face learning with the help of the workshops. And as you must have seen in this program, over a period of 6 weeks, you will have the opportunity of meeting face to face for 6 hours on after 3 weeks and 6 weeks to the facilitators and the mentors of the program. Next slide. What do we need if we have to do blended learning? For doing a blended learning, we need high quality e-content. And as Dr. Praveen said, over the last 5-6 years, we have developed high quality e-contents to be shared on the e-learning platform. This is a digital platform. We are using WhatsApp at this point of time, but these are created on digital media, which are peer reviewed, evidence-based, and up to date as per the World Health Organization guidelines. You also need a lot of facilitators who are working online and on site while the workshops are going to happen. In addition, as rightly said, we need program coordinators. We need program implementers. Implementers are the nurses. You heard about Ira and Ankita. In addition, Dr. Pratima, who are the backbone for the implementation of the entire program. In addition, we need state mentors and the mentors in the country who are going to lead the face-to-face workshop, which will happen at the end of 3 weeks and 6 weeks. So it is a complete hybrid model. Next slide. Why we need hybrid model? What happens is you are able to save time, because the time for which the participants are going to be away from their duty place is going to be less. Then they will be able to give more time for clinical care. There is a flexibility for students to access online material because it is in their hands, on their mobile phone. They can access at their leisure time at home. It is a self-paced learning, self-directed learning. These students have to be motivated itself that they want to learn and imbibe new knowledge. They may be having existing knowledge, but by collaborative learning, they know what the best practices are. And as you have experts in the group who are going to drive the webinars and participate in the discussion, you will get the right messages for the best. There are going to be more engaged in face-to-face. These are going to be small group learning sessions, which will happen at the end of 3 weeks and 6 weeks. There are opportunities for deep learning because the knowledge acquisition is going to be online. And then you will be able to apply the best practices. Best practices using the quality improvement, which you will also learn during 6 weeks by doing small projects. And then the best practices will be implemented as a team, doctor, nurse team, in the units where you are working. We have shown and published in literature that it is an effective way for teaching the young generation, especially the Zoomers, the generation Z at this point. And as Praveen said, we have piloted in 5 states earlier before we are doing this in nearly 21 states and 3 union territories and 4 countries. Next slide. Next slide. I just wanted to share with you that times are not away, that you are going to use some standard treatment workflow for teaching of your doctors and nurses at level 2 units and down below. And these are in the form of standard treatment which are made by ICMR, the HR section, which are endorsed by World Health Organization, India Country Office, and National Health, which is Bharat. And for doing all this, again, you have all this available on the web. But what you have to do is you have to teach this in small groups. In small groups, using case discussion, self-directed learning, and then clarifying doubts and using this by using simulation OSCE exercises. Last slide, please. So as we move forward, I wish everyone a happy, joyful learning. We are reaching nearly 1,000 participants at this point of time, and all of you will be able to get a certificate and even get credit points. So enjoy online contents, the weekly webinars by the faculty and experts, and the 2 workshops which are lined. My best wishes, and I'm very sure the flagship of National India will reach large number of healthcare professionals in the country and beyond country. Thank you. Over to.
Thank you, sir. These were very kind words. Are you able to hear me, everyone?
Yeah, we are able to hear.
Sir, actually, बीच में आपकी आवाज एक दो बार कब आई थी? I think Sanjay also said, but it's only in the last. Nothing. Thank you, sir. Thank you so much for your the guidance you have provided, the kind of key change in methodology of learning and teaching and learning we have seen under your guidance and mentorship. We have now Professor Shushma Nangia, Director Professor and Head of Department of Meteorology at Lady Harding Medical College and Kalavati Children's Hospital. And she's our past secretary at NNF. She is the president-elect 2023. And she has the experience of having the nodal center of facility-based newborn care at Kalavati, Lady Harding Medical College. She's going to tell us about the vision of NNF in teaching and learning, teaching and training of neonatal healthcare providers. Madam, over to you.
Good evening, everyone. And can you hear me, Surendra? Am I audible? So good evening, everyone. It's good to see nearly 300 people here who have joined. And I bring greetings on the occasion of 77th Independence Day of India.
Many have joined in, hundreds have joined in YouTube also.
Okay, that's even more heartening. So we have so many people who've joined for this very important launch on a very important day, which is the Independence Day of India. So obviously the vision of the National Neonatology Forum for teaching and training of neonatal healthcare providers has been nothing less than the highest quality of care to be provided to the newborns and the highest possible quality of training to be imparted to the healthcare workers. So as times are going by and we realize that it's becoming more and more difficult to have everything which is face-to-face, which involves a lot of, resources, time, effort, energy. So the time has really come for something like this, which is blended learning. In this, what I see is that it is a course which is spread over 6 weeks. Many topics have been covered. Obviously, everything cannot be covered. So the important ones have been covered in this. And it's good to have an online session which definitely takes care of the cognitive knowledge that can be gained. But for the psychomotor skill learning, we definitely need hands-on. And for newborn, maybe something more than hands-on, which is just a contact period of 6 hours twice during the 6 weeks, may be just about enough, but may also require some more time where the participants have to be in some of the good units to see. And once they see, they will be able to practice that much more efficiently than just having a contact for a few hours after 3 weeks. What we really need to look into as the mentors and faculty who are here, that our participants get the knowledge which is such that they can apply to their clinical work arena. So our course should be such where healthcare workers wish to learn and they wish to join it. Currently, although we are happy to see that 800 plus participants are there. But in a country with 21 states, 3 union territories and international participants, it is still 840. So I think with so much effort going in, we should have the numbers, which should be more. And this is after some help from the national, the different healthcare regions from some of the states. So what we need, my message to all our faculty would be that we really need to see the feedback from the participants and also your own feedback in teaching this course. And based on that, maybe we can think of if there is anything that is needed. I'm sure there is always room for improvement if there's something needed. So for the subsequent way, do we need to change the methodology? Do we need to change some of the topics? How do we need to go about or the training methodology? So a lot of responsibility rests on our mentors and faculty to to give genuine feedback after they have taught the course. And I wish all the success to this course. All the participants have a happy learning. All the facilitators, they put in their best foot forward to teach the healthcare workers, and there is a good good rapport between the participants as well as the faculty, so that not just during the 6 weeks but even thereafter they can approach the faculty who has taught them for any queries, any kind of clarifications that they need. So I wish all the success to the course. Thank you very much, Surinder, for this opportunity.
Thank you, ma'am. And very pertinent points said by you, ma'am. We will take care of all those during the course and after the course. And as Dr. Praveen said, the ratio here of trainers, mentors and faculty to participant is to the tune of 1:4. So this is the closest observed kind of ratio which can be provided, though it is still virtual and the contact periods will be lesser. Dr. Alok Bhandari, our Vice President, NNF, he was our Secretary and Treasurer earlier of National Neurology Forum. He's the person who has made all those liaisons with the state groups, and he's responsible for bringing all the state president secretaries together this year. And we are really thankful to you for this. You kindly address on this occasion. Few words.
Good evening, friends. On this Independence Day, as we go through the history of country 77 years into the new India, similarly, it reminisces me that the NNF has been a torchbearer for last more than 4 decades when NNF came into existence, that we are the pioneers in the field of neonatal healthcare, but we still have to ensure that the effort goes on and good neonatal healthcare practices are taken to remotest of remote and poorest of poor are benefited by these programs and the policies. One thing which is a stumbling block, which I find slightly tangential when we talk about neonatal healthcare equipment, that India is not Atmanirbhar still in many of the equipment categories. And I think we at NNF should take a lead in that also, develop a vertical where we can make affordable and quality healthcare equipment available in our neonatal units for neonatal care units. And then second is their annual maintenance and to carry out repairs of these equipment. So many places, big multi-million investments are lying idle because either the technology has been outdated or there is no facility to repair those equipments. So that is another one area where we would like to work, and definitely best wishes for this good program. And let's enroll more and more people into NNF activities and NNF folds. And definitely, as Madam said, a good feedback is required so that how do we extend our activities further for benefit of the masses. Thank you, please.
Thank you, sir. Very important things said by you. And we're really thankful for bringing whole of all the state NNFs together in this fold. We expect more from you, sir. Dr. Amit Upadhyay is senior consultant at New Tema Hospital, Meerut, past HOD of LLRM Medical College, Meerut. He's the treasurer of National Neurology Forum right now, and he's going to share the experiences of the NEOQUIP phase 1. Amit.
Thanks, Dr. Surendra. It has been really wonderful listening to all such great neonatologists and workers and servants of NNF. And they all have worked so hard for last so many years. And this program is quite unique. It has been tried before. And 6 weeks of togetherness with faculty makes you learn a lot. you can always, this program is weekly. You have one topic and discussing that with almost 8 to 10 faculty from each state. Some states have even more. This will be a wonderful opportunity. As a treasurer, I will make sure that your offline workshops, you have it properly and your finances are secure and you get them in time. I will ensure that. And best wishes to all of you. Have a wonderful workshop and a conference. Thank you.
So thanks, Amit. And since the first phase was quite successful, and despite being self-funded, as Dr. Praveen said, we hardly have any issues of providing funds and reimbursing the expenses of the physical workshops so far. So we hope to assure everyone here, as said by the treasurer, that all the expenses met for physical workshops will be taken care of. And for for neighboring countries like Nepal, Bhutan, Maldives, and I think I got messages from my friends in Nepal that it is it's so much is being talked about it across Nepal. So I think there you are also able to manage your funds there, and you have found your way. For the program details of Phase 2 NEOQUIP, Dr. Murki, are you driving?
No, I can talk. I'm not driving and I'm sitting.
So
Dr.
Srinivas Murki is our is a leading neonatologist, a past PGI student, Paramita Children's Hospital, was in Fernandez Hospital, Hyderabad, is a master teacher, and people just love his lectures. He is the Joint Secretary of NNF right now, and he's the major advisor of, along with Dr. Shushma, the advisor of NEOQUIP. Dr. Burki.
So thank you, everyone, and welcome all the delegates, faculty, and my special welcome to all the faculty and delegates of Maldives, Bhutan, Nepal, Bangladesh. So, and also the other faculty and delegates of the entire country. It's a pleasure to see 800 people joining this group, and also another 150 to 200 faculty being part of this group. So just to summarize, I think we have already highlighted it's a blended course. You have already seen day one of the WhatsApp group activity. This group activity is divided into 25 groups. Maybe all of you are not able to see the groups, but there are 25 groups in this NEOQUIP 2. Each group is dedicated to a state or a country, and this group will run for 6 weeks now. The second part is going to be the weekly webinars. One of the webinar is going to be today, and that webinar is going to be delivered by Dr. Anu Tukral. It's on a quality improvement program. Like this, today's webinars, there'll be multiple webinars, almost twice a week for the next 6 weeks. Now, the third component is the offline workshop. That is where we would like to improve the skill building of all of you. So I request all of you to ensure that take your time to attend all the offline workshop, because this program is complete only with the offline workshop and only 2 point of contacts. So one after 2 weeks or 3 weeks, and the second one is at the end of the program. There'll be offline workshops. The offline workshops will definitely involve a lot of training, skill building, procedures, equipments, all that Dr. Alok Bhandari was talking about. Training of people on equipment, how to use the procedures will be dealt in detail during the offline workshops. So the another very important part of this NEOQUIP program is also building relations and ensuring the bond between the faculty and the delegates continue even after 6 weeks or while the course is going on, to build QI programs for your hospital, quality improvement programs for your hospital. You can choose a problem and try to highlight that problem using QI models, and especially the point of care QI models, so that you can come out with papers, you can promote with activities by which you can present in the coming NEOCON of Nagpur. So that's all, I think. And the other thing is, it's a certified program. All of this is certified by the Indian Nursing Council and also by the Delhi Doctors Council. So I think all of you going to have a wonderful time 6 weeks, but keep yourself free for this 6 weeks. It is going to be complete neonatology for all of you. So thank you for giving this opportunity, and I'm sure all of you are going to enjoy this 6 weeks of interaction. Thank you.
Thank you, Dr. Srinivas. I can, Dr. Dinesh Chopar, sir, as Dr. Debrari has always suggested that we have to keep the time, and the time is to be such that we don't encroach on the teaching, and we are about to finish on that time only. Dr. Dinesh Tomar is down with fever and is not well. I really want to wish him speedy recovery. So he is not able to join us. I see, sir, Dr. Dinesh Shilla has raised some hand. Dr. Dinesh, you want to? Dr. Dinesh Shilla is our past Joint Secretary and Vice President-elect. If that is, Dr. Dinesh Chilla had raised. Sir, Dr. Praveen, before I say a vote of thanks, do you want something else? Anyone else or somebody?
No, I think have been great. I think let's get going with the actual teaching activity. You can.
So I really want to extend the vote of thanks to so many. So the list is long, and there are firstly all the neighboring countries. Faisal, thank you. Thank you so much. There is Dr. from Nepal, and Faisal, there are 2-3 more people from Maldives who are here. Really thankful for enrolling it. And Doctor, I hope it becomes a success over there. And any issues, any things, I think the team is ready to coordinate for even offline workshops as well. Dr. Shrestha, Dr. Sanjay Day, thank you, sir, for this. And there are state representatives from all the states, most of the states. And there are executive board members who have joined, like Suman, Dr. Pinaki, Kavita there, and Mangla Bharti is there. Dr. Arun Nyopen is from Nepal. Thank you all, sir. And our big thank to all the participants. Dr. Dheeraj Mohan is here. Dr. Bhashwati Gosal. Ma'am, I'm missing out on names. They're mentors, they're teachers. They are Dr. Rajesh Mehta, I must not forget. And sir is the consultant child health WHO, now the advisor. Sir, मैं हमेशा भूल जाता हूँ. ठीक है. WHO Southeast Asia region office.
राजेश मेहता को भी सुन लो एक मिनट.
मैं तो बोलिए.
No, at our age, I think acknowledgement is good enough. But since Ashok invited to speak, I only have one suggestion. I was just writing in the chat. It is such a wonderful energy from the first hour, which I can palpably feel. So since mentoring will be available beyond 6 weeks, Praveen mentioned potential of QI projects getting completed. So one of your outcomes of this whole process could be number of QI projects completed, in addition to learning outcomes which you will measure. So my sense is that documenting all of this experience well, doing some measurements will actually keep pushing us forward to achieve more and more. So well done, and you have all the blessings from seniors as well as energy from juniors. I think we are placed in a very good spot to help the newborns in this country and neighboring countries. And I like the idea that poorest of poor must benefit. So that should be the case. Thank you so much.
Thank you, sir. Thank you.
Hello. Sir, thank you all, and thank you all the participants. And the webinar, I just will hand over to the Dr. Pratima Anand. Dr. Pratima, you are here?
Namaskar.
Mangla Bharti, sir. Mangla Bharti, sir, is
the moderator. You please introduce the program, both the moderators also, Mangla Bharti and Ira Deva. Pratima, please introduce. Let me just introduce the moderators for today's webinar. Dr. Mangla Bharti from Institute of Obstetrics, Chennai, and a very senior neonatologist in southern part of India, in whole of India for that matter. And Dr. Ira Dayal, who is from AIMS Rishikesh, senior nursing tutor from AIMS Rishikesh. Sorry, I must be not telling the right designations, Ira. So forgive me for all those things. Mangla, please continue.
Good evening, everyone. Again, Independence Day wishes for everyone. So without wasting much time, let's get into I'm very happy for this opportunity to be moderating the first live webinar of the NEOQUIP program. We all know that we are just going to have 12 webinars, so 2 webinars per week throughout this program. So I have the pleasant task of introducing the topic for the first webinar. I think all the participants would have had a look at what we are going to discuss today in this webinar. So it is about learning the basic principles of quality improvement. Some of you might have wondered, okay, see, even the very word NEOQUIP has this quality inbuilt into the name of the program itself. So some of you might be wondering, so we have come here to learn the basic concepts of neonatology. So what is that? And we have chosen something like quality improvement as the first topic. So what has it to do with neonatal care? So we all know what we mean by quality. So it may be a difficult term to define, but practically quality is something like some standard of care, or simply how good or bad we are compared to the others who are performing well. So throughout this course, while it's very important for us to learn lots of clinical aspects, lots of science, how what are the basic problems of the babies, how those problems have to be tackled, what we can do about it. So that is not enough, right? So just learning the theoretical part, or even some practical parts of procedures and all, if you fail to ensure that whatever needs to be done has to be done in a quality way. That means we have to deliver it in the best possible way, and we need to, and it is easier said than done. And quality is not a one-day task. So we need to thrive to improve the way in which we are delivering neonatal care, the quality of the care over a period of time. That has a very, very important bearing on a newborn's outcome. We all know in today's era, it is not enough if we just save the lives of newborn babies. So we have to focus a lot on intact survival. That means we need to save a baby, and we need to, at the same time, we need to ensure that this baby has all its senses and organs functioning in an intact way. And this baby will be contributing significantly in all its capabilities. So how do we, first of all, analyze that are we delivering quality care? Whenever we want to do something, is there a structured approach to understand? So what are the things that we should be, what are our problems? And are we delivering quality care? So where do we get the data to find out the comparisons, whether we are doing good or doing bad? And then obviously, then we start working towards improving the outcomes. So today's webinar will be to introduce this basic concept of, for any neonatal problem, the common problems what we face. So how do we just say that to tackle, and quality, just only one more sentence will say, it is not a single man's job, right? It is not, whose responsibility is quality? Is it an administrator's responsibility? Is it a physician's responsibility? Or is it a nurse's responsibility? So quality is, we all know, is a teamwork. No single person can so improve the quality on his or her own individual contribution. So we all need to come together as a team. It's a teamwork. So with this introduction, so we do have a very experienced and an eminent speaker today to teach you about what are the basic principles of what do we mean by quality improvement, and what are the, it's a very simple tool available for us to improve the quality in whatever things that we are doing. So I'll request Ms. Ira Dayal to introduce today's speaker. Thank you. You are on mute, Sira. You are on mute. Please unmute yourselves.
Am I audible, sir, now?
Yeah, you are audible.
A warm good evening to everyone present here. It's a great pleasure to introduce Dr. Anu Sachdeva. At the moment, ma'am is working as additional professor in AIIMS, New Delhi. She has extensive work experience in both pediatric and neonatology in esteemed institutions like AIIMS, New Delhi and LHMC. Time does not permit me, but ma'am has numerous and significant publications and awards, starting right from her early days where she got the University Gold Medal in MBBS. And even for the work from which we are going to learn from the next 6 weeks, ma'am has been awarded many times. So with this small, humble introduction, I welcome you, ma'am. Over to you, ma'am.
Thank you, Ira, and thank you, Dr. Mangla Bharti. It is indeed an honor and my privilege to be here for talking about introduction to the POCI methodology. So heartfelt thanks to my teachers, senior colleagues, team NNF, friends from India and SEER. When we talk about point of care quality improvement, I would actually say that this was not a one-time process, but I would call it a movement to prevent mortality in mothers, newborns, and children, and ultimately lead us to making a progress towards the global strategy for women, children, and adolescent health, and ultimately sustainable developmental goals. This was developed way back by WHO CIRO, WHO Collaborating Center for Newborn at AIIMS and ASSIST, and was supported by UNICEF, UNFPA, USAID, and WHO as a collaborative movement in Southeast Asian region. Today, what I talk about on point of quality care improvement is the experience that our team has gained using POCI for quality improvement, not only in our own institution, but outside our institution. And I would share a short experience which we have had in the state of Madhya Pradesh. So with those words, I would request all of you to have a look at this short video, try to imbibe what you understand from this video, and then I'll start with my talk. So is my screen visible?
Yes, Dr. Anu, please go ahead. Your screen.
Thank you so much.
Sound is not there. This becomes a problem sometimes. Sound is not there.
Dr. Anu, maybe you can give the voiceover. We don't hear any audio.
Mangla, you do that.
Yeah. Dr. Anu, we are not hearing any audio. Is it okay? Shall we go ahead?
You're not able to hear the audio?
Yeah, there's no audio. Only we are seeing the video.
No problem. I think we can close this video for the time being and we can actually take on to the, yeah. Okay, so we can start sharing our screen. Is my screen visible?
Yes, yeah.
Okay, so the reason I was showing that video was, and I can give you an idea of the video in the next about a couple of seconds, is that the story that we've all grown up with of the rabbit and the turtle is that the rabbit was the one who was little careless, slept under the tree and ultimately lost the race. But then the rabbit did some thinking and analysis, and finally he teamed up with the turtle and they won the race together. So when you work with somebody as a part of a team, when you discuss the problems, when you analyze the problems, when you actually set a goal, but at the same time, when you start moving towards that goal, you have people accompanying you. You have people who analyze the problem together. You have people who walk the track with you. The success feels very good. So what we'll talk about now in the next half an hour will be about teamwork, and that is the key message behind point of care quality improvement. So what is quality? Dr. Mangla Bharti just told us that in healthcare, quality has multiple meanings. So let us start with a basic premise that yes, in the automobile industry, when you go and buy a car, what would you look at? You would look at the safety, you would look at the reliability, you would look at the gas or the petrol or the diesel mileage, and of course, you would look at the owner satisfaction. So automobile industry has a way to look at quality. When you talk about airline, it would start with service of staff, ease of check-in, ease of sitting, your seat comfort, and so on. So quality in healthcare would be a little different from airline industry or automobile industry. And that sets us all thinking that why is actually quality required? Why should I actually be caring beyond my margins or zones of comfort? Or why should I actually go a step forward and thought about QI? And I hope that none of you would be actually dozing off while I speak, and I'll come to my objective straight away. Why is quality of care required? And the two slides that I have now, this one and the next one after that, tells me the burden of deaths in lower middle income countries and high income countries just attributed to poor quality of care. And the number is 8.4 million annual deaths. This is 15% of the total deaths in LMICs together. Imagine 8.4 million deaths attributed to only poor quality of care. Now, if you actually look beyond your normal healthcare routines, you would realize that 60% of these deaths are because of poor quality, and 40% of these deaths actually occur because the health system is never utilized. In fact, if you look at the amount of money which is lost or per year productivity which is lost, it is about 1.4 trillion US dollars. This problem is not limited to LMICs. We would always lament that, because we don't have resources, that is why we have poor quality of care. The understanding from high income countries also tells us that 10% of the patients are harmed while receiving hospital care. And out of every 100 hospitalized patients, 7 have a healthcare associated infection. Coming to the context that we are all here for, the newborn context, 1 billion newborn deaths and half of the maternal deaths each year can be prevented if the quality of care is optimal. 1 in 8 healthcare facilities all over the world does not have water service. 1 in 5 does not have sanitation service, and 1 in 6 does not have proper facilities for hand hygiene. 1/4 of the world's population is living in fragile contexts, and hence we as frontline healthcare champions are always challenged in delivering quality essential care services. So that was the context. And understanding, if we actually look into our own selves, if the burden is too hard, why is it that we were waiting for so many years to learn about quality of care, to learn about quality improvement? So a simple mnemonic, STEEP. So first thing is that when I say good quality of care, I should actually analyze it as being safe. That means do no harm. Second, it has to be timely. Timely means that when my patient desires that care to be delivered to him or her, that care should be delivered. E is effective. So whenever a patient seeks care, we should get the right medicine, and the medicine should be effective. So safe, timely, and effective. The 2 other E's are equity. That means they should get equal care irrespective of caste, color, creed, money status, and so on. And efficiency means it should be as fast as possible, and it should be delivered in the best possible way. And P stands for the most important thing, that is, for the entire work that we are talking about, for the entire talk that I am talking and you are listening, patient has to be the center of focus for all quality of care, all medical care that we deliver. Now, As healthcare professionals, I understood a lot about quality. I understood that there is a context. We have to deliver quality. It is the essence of the day. There is so much of importance related to it. How do I learn? How do I benefit as a professional? Number one, it gives me a lot of joy and satisfaction if I deliver optimal quality of care for any patient or any newborn or any mother. Number two, I learn how to put data into use. So routinely, there are hundreds of registers being filled in newborn care units, in NICUs, in other hospitals, but no one is actually putting that data to use. We analyze data, we measure data, we put that data to use. Third, which is important, is we build up teams which work together, teams which learn together, teams which work towards optimal quality. And finally, we build up leadership skills. We would identify some hidden leaders, which actually can build up new teams and send and hardwire this quality improvement mission so that we can deliver optimal quality to our patients. What is POCI? POCI is nothing but a 4-step simplified approach. When this point of care quality improvement methodology was developed, we had a coaching manual for the facilitators on how do they go about teaching the learners, and a separate learner manual which had bulleted points, a proper index, hand-holding, having case studies, having exercises, giving them scenarios. They were analyzing, they were understanding each step from the learner manual, obviously mentored hands-on by the facilitator. So this is how POCI is delivered. There are practically 4 steps. The first one talks about identifying a problem. Now, you would argue with me, ma'am, there would be hundreds of problems that we would have in a scenario. Well, yes, we would have hundreds of problems. But then POCI helps you identify and prioritize which problem is the one you would start with. So whenever a batsman comes for batting, he would obviously think of that I may get googly 6 balls. I don't know which ball to bat. But what I have to prioritize is that if this person throws, then this ball is going to come like this. So you need to prioritize that out of those 100 problems, which are the 1 or 2 which are actually dear to our team, in which we can actually achieve success soon. So identifying a problem, identifying a team, prioritizing your problem, and finally getting ready to start. This is the first step of POCI. Step 2 talks about analyzing. Obviously, if I've identified a problem, I need to analyze why this problem exists. And I have multitude of tools for that. We'll come to that in the next slide. The third thing is, having understood that problem, having analyzed that problem, the third step is, I cannot simply say that, this is the solution, go. To give the solution and you will achieve the optimal outcome. No, this is not what POCI teaches us. POCI tells us, go step by step and follow the PDSA cycle, which is the third step. So PDSA, we all know, this mnemonic is familiar with all of us, stands for plan, do, study, and act. And finally, the bright red box that you see on the rightmost part of my slide is sustaining improvement or hardwiring or ensuring that, yes, whatever work you put in, whatever hard work you've put in, that is here to stay. So 4 steps of POCI, don't by the colors of the steps or the content of the steps. We'll just come to that in a second from now. Step 1. So I just told you, select a problem which is a low-hanging fruit. What do I mean by a low-hanging fruit? To make things simple, the newborn deaths in my unit is quite high. I want to decrease the newborn deaths. Is that a good project? No, that is not a good project. Take something which you can address as a team of 5 to 6 members. So take a low-hanging fruit. For example, what you can actually take is something like trying and improving the hand hygiene of your unit, or trying and improving kangaroo mother care in your unit, because that is something which is under the control of your team members. That is something which is doable. Step 1, then you form a team. You are not Arjuna, that you actually going to lead the entire war yourself. You need a team, and take members who are inquisitive, who are cooperative, who are forthcoming, who are multidisciplinary. So don't take a team of entire doctors or entire nurses, mix and match. It is not important that the head of the department has to be a part of the QI team. No, that is not mandatory. Yes, the person has to be informed, but the team should be of people who are multidisciplinary. They should not be like-minded. For example, if I make a QI team, I should not take my 5 friends with me. No, take people who think differently, who think out of the box, but are forthcoming and are interested. And the third one is, I will formulate an aim statement. Details, don't worry. We have a full website which is functional, which is www.pocqi.org. Everything what I'm talking today, the resource material, multitude of webinars are available on that website. So this completes my step 1, which is identifying a problem, forming a team, and finally making an aim statement. And details of this we will be discussing with you through the weeks when we talk about how to formulate an aim statement. Step 2, having identified a problem, I should now know how do I analyze. Now my problem is so big, and I'm aware that this problem is because of 100 causes. So out of these 4 tools, I can choose any one tool. Fishbone, classically, whatever the name says, it looks like that. So make a fish and put down all the causes of your problem. So suppose mothers are not doing kangaroo mother care, put it down. Nurses are not convinced, doctors don't want to work, parents are not interested, grandfather is not coming. So put down those problems and you'll identify which are your bottlenecks. The next part is 5 whys. Keep on asking why till you reach an answer. For example, mothers in the neonatal unit at AIIMS New Delhi are not doing kangaroo mother care. Why? They don't get enough time to rest. Why don't they get enough time to rest? Because they have to come every 2 hourly to pump milk in the NICU. So they have to discontinue KMC and pump milk. Why do they have to do so? Nowhere it is written that the milk has to be pumped 2 hourly. So they do so because it's protocol in the unit that 2 hourly pumping has to be done. So ultimately, you found out a cause because of asking why, and why. So Fishbone and 5 whys help you to identify why a problem is occurring. The third one is Pareto principle, and the fourth one is process flow chart. I do not want to burden you with the way that these tools are used for analysis. As we see a QI project, which I shall be sharing with you in a short while, we shall try and understand what is Pareto principle and what is process flow chart. Step 2, after you've analyzed the problem, what you do is you develop indicators. Now, giving you a small example. So you have X number of babies born in the unit, out of which X prime are the babies who actually receive care. So this X, which is the babies born in the unit, is the denominator. The babies who receive care tells me the process, and ultimately what I achieve is the outcome. Let me take an example. So if the number of babies born in the unit is about 2,000 per year, the process which can help me identifying the route towards quality improvement is how many babies are dried, how many babies receive skin-to-skin contact, how many babies receive temperature monitoring, and outcome is the outcome of this process. If they are dried, if they get skin-to-skin contact, obviously less babies would be hypothermic at 1 hour after birth. So these are small ways in which we try and develop indicators. And this is important because otherwise we will never know which journey we are treading on. We will never know where we are going to. How good or bad is the track till we actually keep on measuring this data. Step 3 is actually plan, do, study, act, cycle, which tells us what we are going to do, how we are going to do, and what did we learn out of this, and what are the results. If everything goes well, I simply adopt this intervention. For example, in kangaroo mother care, we found out that the mothers could be helped by bringing in fathers in. So we brought in the fathers in the newborn unit. How did we do it? We requested the fathers to come into kangaroo mother care. We learned that even fathers can be a good care provider. And the result was that the kangaroo mother care duration, which was initially only 3 hours, actually went up to 8 to 10 hours. So we adopted it as such. Adapt means you make minor changes and abandon. For example, you started skin to skin contact, but the babies started falling off the mother's chest. So you have to rethink on your PDSA cycles. Why do we do them is something which might be going on in your mind. We do them because we want to test small. These in healthcare stakes are very high. Test small so that whenever you feel that this is not going the right way, you can always make an alteration or an iteration. So when I give this example to you, it will be much clearer. So this was one of the QI projects that we did in our unit to improve kangaroo mother care. And we used POCI approach to address this quality gap. The baseline kangaroo mother care in our unit was 2 to 3 hours. And we have an honest submission. This was about 7 years back. And let us see where are we today. So we used the POCI approach. The facilitators helped us to develop our own skills in quality improvement. And we used the 4-step approach again. We formed a team. The team members were our nurse educators. I would like to name her. This was Mrs. Veena Joshi. We had 4 bedside nurses. We had 2 mothers and 1 resident doctor. All babies in the unit who were eligible for kangaroo mother care, we took them in our study. This was our aim statement, and let us together read through it. To increase the duration of kangaroo mother care for low birth weight babies from 3 hours to 6 hours by the end of 6 weeks. You see 3 numbers here. 3 hours, whatever was our baseline data. 6 hours, the team felt that yes, they could go up to 6 hours. And 6 weeks, because we felt, why should we say 2 weeks or 3 weeks or 10 weeks? Let us keep something, a time frame which is challenging, a time frame which is achievable at the same time. So we did some baseline data collection. The bedside nurses collected few things about the demographic profile of the mother, which was already being recorded in the register, and KMC hours were already being recorded in our nursery charts. So this is what a fishbone looks like. A big fat fish with a spine in the center, and we have issues which are parked on the lateral spines. So why did the mothers not do? When we talked to them, they said, we don't have appropriate knowledge. We don't have family member support. The NICU environment is so stressful. I cannot come in the night. The doors are locked. The baby, the diaper was possibly large. They said baby is becoming hot. There was lack of formal counseling related to KMC. Now, had we not sat and talked as a team, we would have never been able to identify the reasons for the lesser duration of kangaroo mother care. So, the circled ones are the ones which the team that had been formed thought that these would be the interventions that we would do to improve kangaroo mother care. So this is the Plan, Do, Study Act. So let us go back. So this was formal counseling, imbibing support from family members, and ensuring mother gets adequate rest. Now we need to understand today, how did this team do this? They collected baseline data. They implemented the comprehensive, CPNC stands for Comprehensive Postnatal Counseling. Then we facilitated the nursing staff to some extent. We allowed fathers. If you remember, one of the intervention was to take in family members. And we also asked the nurses regularly that why was this baby not being given kangaroo mother care? We analyzed the data. And finally, let us see what happens. So this is one of the team meetings, talking to the father, talking to the mother. And this is a group of nurses who actually helped in doing this quality improvement process. So the duration increased to 6 hours, and almost 2/3 of the mothers did kangaroo mother care more than 6 hours. Interestingly, there was a kind of competition, and the longest duration of kangaroo mother care that we achieved in our unit during the same time was 16 hours. There was active involvement of all the family members, and we started seeing improving kangaroo mother care after few months. So if you see the chart here, this is the dates on the x-axis and the duration in hours on the y-axis. Very easy to plot. It's a simple Excel chart. And we actually saw our kangaroo mother care going to 8.2 hours. We then, as a successful team would do, increase the challenge and set it to 10 hours. We celebrated success regularly. Our nurses were so happy. You can see those smiling faces. You might be recognizing many of them. They are still with us in the unit. And then it actually went to 10 hours and we increased our goal to 12 hours. So this is how we kept on challenging. And today, if you ask me, for these babies, the kangaroo mother care duration actually ranges from 12 to 14 hours per day in the unit for this particular infant group. The journey did not stop here. We actually ventured to working with improving breast milk intake, decreasing false alarms, improving communication, and decreasing transcription errors. What you see as multiple numbers jotted on this slide is actually the baseline value, the target value, and the time that the team decided that they would work to achieve this particular number. This was not all, and this actually brings me to step 4. So step 1 was identifying a problem, forming a team, and prioritizing it, and forming an aim statement. I need to analyze and develop indicators. I need to run PDSS cycle. And 4th is sustainability or hardwiring my QI project. I identified as a team, we identified sustainability tips. Critical steps need to be identified by the team, which leads to changes. Allow parents, allow caregivers to play an active role, take feedback. And one important thing that we understood was always plot data and make it visible as charts on your NICU wall. The nurses feel happy, the doctors feel happy, the parents feel happy that yes, the work is progressing in the right direction and to a good goal. We kept our members motivated using WhatsApp and smartphone apps, continuous positive reinforcement, recognition as the champion of the month, and we got them specific nameplates, appreciation by the head of the department, and celebrating our success frequently. So, with these few slides, I think we've unfolded the mystery behind point of care quality improvement, simple 4-step approach targeted towards improving quality, saving newborn lives, intact survival, and the welfare of the newborn as a whole. The slides that I have now have been collated from the last 5 years from some common questions, which all of you would have, and we will always be happy to take up questions in the end. So a question that normally is asked to us by our participants when we do this is, our staff members just don't want to work. So they would always be burdened by this extra approach, and this is an additional burden. I mean, we are working like in shift duties, and how do you think this quality improvement would help? Number 1, it decreases the resistance to change because you are using data and then making a decision. Fine, you are improving communication, you are improving motivation levels, and remember, if you start a journey, you will always find some obstacles, some resistance, but finally, people will get curious, they will get convinced, and they will join the move. The second important question which we see is that, so this icon actually fixes all. So data collection, well, I'm already collecting so much data. Why do you want to punish us by taking it an additional burden? Please remember that decision-making is always data-based and decisions are always made on evidence. So once you do a QI project, do share it on a public platform, collect data, make decisions based on data. Only then you'll be able to do hardwiring and your quality improvement would stay. So don't feel overburdened by the data collection. Do only thoughtful data collection. Don't keep on piling bricks and add to your burden. So another question is that when everything is based on evidence, so while taking rounds, you would say, no, we would do this because it's based on evidence. So what is the need to use quality improvement? We already know that whatever we are doing is based on evidence. Please understand, evidence tells us what works and QI tells us how to adapt the process in our own context. Is my point clear? Evidence will tell me what works, but QI will tell me how to adapt that process of care to my own context. I'm bogged down, There are so many problems in my unit. Should I start 100 QI projects at the same go? The answer is no. Prioritize, start with only 1 or 2 projects which are simple. Take up more projects as the team gains confidence, as the team builds up, understands QI methods, as the team understands these methods and achieves success. So I need one extra quality person in the unit, not necessarily. It is an embedded culture. It's a teamwork. Yes, you need a local champion who to quick start the improvement projects and provide some extra support to the frontline staff. But it is not that you need a designated person to do QI work for a project in the unit. Do we need continuous trainings? Is today's webinar enough or not? Initial training, this is just hand-holding support. Once you learn the basics, the best way to learn QI is not to listen to Dr. Anu's webinar, not to see website, but to do a quality improvement project with your own hands. So go, set the ball rolling, take help from your mentors, facilitators in your units. They are already well trained. The major learning actually comes by doing the quality improvement project. Does it create additional work? The answer is no, no extra time. You can manage it in your routine work. Actually, once kangaroo mother care improves, obviously your workload would decrease. Baby would exit the unit faster. If your breastfeeding rates improve, you won't have to make formula feed. Your work is actually being reduced. Bring efficiency into your system, reduced wastage, ensure optimal usage of resources. Madam, I'm trying my best. I'm working so very hard. So why should I be using QI in the first place? Please remember, it's a system approach. It is a management approach. The system may not be working at its best. QI will help you involve more people and help improve the system performance overall. So the broader objective, which we don't speak so often, is to improve the performance of the system as a whole. Just 2 or 3 slides more, and this work needs mention because this was a team effort, Herculean effort from the state of Madhya Pradesh, again using the POKI model, multiple SNCUs, multiple PDSS cycles being done, not by us definitely, by the special newborn care team members, by the frontline healthcare professionals. What our team did was only mentoring, and this is the huge improvement in reducing hypothermia, reducing the use of inadvertent antibiotics, improving feeding initiation, and you actually see the numbers are reflective of what is the truth, what we saw after we instituted quality improvement in the state of Madhya Pradesh. So identify champions, allocate responsibilities, work as a team, and continue your good work to achieve successes. POKI crosscuts all disciplines. Please remember, if you do not repair the problem now, you will only keep on repeating the problem. Quality is the culmination of high intent, sincere effort, intelligent direction, and skillful execution. That's all from my side, and I'm happy to take any questions if there are for this webinar. So the first one is the POKI website from which the material has been taken. We have our own AIMS QI network. Lot of material for those who are interested is available at IHI website, which is www.ihi.org. I can share my presentation with Dr. Pratima, who can share it with everybody. You're free to use and refer to this material which is available. Thank you so much.
Thank you, Dr. Anu. It was a wonderful lecture. It was very, very crisp. All the concepts were made very clear. We request all the participants, see, we do have a 15 minutes time allotted exclusively for interaction. So,
Mangla, there's a question in somewhere.
Yes, we are getting to that. Yeah, some 1 or 2 questions are there. We will just wait. I think more questions will start coming in. So maybe just take a minute before we just giving more time for the people to start. You can, already it has been pointed out, you can please make use of the chat box. You can type your questions in the chat box. All the questions will be taken here. And somebody who wants to speak, there is an option of raising your hand also. You can raise your hand. You can directly ask your questions.
There are a few questions in the QA box also.
Yes, we'll take up. Dr. Maybe we'll start with the first question that came up. So there was a question from Anand. So see, he has raised a question. See, the different people do different PDSA cycles for the same problem, and they may come up with different kinds of answers. So he just wants to know, so is it possible to compare? Can we just learn from the experience of the others? Because as different things work differently in different settings. So how do we compare these various QA process done in different units? How do we learn from other people's QA?
Thank you for that question, and very interesting question, and very well placed. So why do we do QI? So we do QI to understand whether a particular evidence, the method that it works in our particular context. So if already a QI has been done in a particular unit and the unit team has used a particular PDSA, you can obviously learn from it, understand from it. But it may so happen that what worked in their context may not work in your context. So two important points. One, do not do multiple PDSAs at one go. The problem is that you will never learn what worked and what was the outcome which occurred, contributed to. So do PDSAs step by step. So that you should remember. Second, the PDSA which worked, you can always learn from the other teams. But it may so happen that it does not work in your context. You can obviously use the same idea or the change idea, make it a PDSA cycle, but do run it in your context, collect data pre that change idea, and after that change idea, try to learn what is happening in your unit. It may so happen that the same PDSA works, it may so happen it does not work. Then you have to pick up another PDSA which you think could possibly work in a better way. So the answer to your question in two simple words is yes, you can use the same change idea and try and do the PDSA, but your context might be different. So always do one PDSA at a particular go. And the second important thing is that your context would be very different from other NICU contexts. So what works, only your team will be the best decision maker to decide what works in your unit.
Yeah, thank you, Dr. Anu. I think we do see a lot of people typing thank you messages and congratulating Dr. Anu on the wonderful. There's no doubt it was an excellent presentation. But again, a kind request to all participants.
Mangla,
Yeah.
can I just tell you about the question from your YouTube?
Yes,
there's
please.
A question.
Yes,
there's a question in YouTube live chat.
Yeah.
Dr. Anu, it's a very tricky question. In fact, I have the same thing. I'm asking the same question. My question is what? He says, Banri Kirim, I don't know where is she from, he or she from. My question is what we can do to get the cooperation of the whole unit for a QI project. So even I have the same question. मैं पूरी कोशिश कर रहा हूँ, फिर भी अगर पूरा cooperation नहीं मिलेगा, अगर बॉस नहीं मानेगा तो आप कैसे करा लोगे काम? मैं सारा एविडेंस भी ले आऊंगा, सब कुछ कर दूंगा. I will give a good project also. I have good intentions also. अगर बॉस नहीं मानेगा तो कैसे काम होगा? I have the same question.
So if I can answer in a single line, that this is not the scenario, or the scenario is not different even at our end. It's only how we perceive that scenario. Now, if you think that somebody is going to create an obstacle or somebody is not going to listen, why do you have to worry about it? That is not your problem. That is his or her problem. So just stop thinking about it for a moment. Number two, whenever you start a QI project, there would be about 30 to 40% who would be with you. So pick up those people, pick and choose them. They would be efficient, they would be hardworking, they would think differently, they would think out of the box, they would come up with different ideas. While you are doing this, another 40% would be just sitting and drinking tea or drinking Pepsi in the unit. Let them have that. Once you start achieving success, those 30-40% people would definitely join you, seeing the team success, seeing the team work. The last 20% would be laggards. Let them be laggards. Let them stay there. Don't get boggled or don't get worried by people who are not supporting you. It's a small QI project. You don't have to worry about higher stakes, or just think as a team. It is going to bring joy. It's going to bring satisfaction to you. That is the thing which actually helps me get a night's sleep when I go back. So keep your mind peaceful. There would be some people, they are not But when you have handful of good people in the unit, QI works. Don't worry.
Thank you, Banri. I think Banri would have got the answer. You just mute yourself. Vidhan, can you mute Anupama?
Yeah, thank you, Dr. Anu. We have been talking a lot about quality. A kind request to all the participants to improve the quality of this interaction. So please do away from posting thank you messages. There are lots of, we're finding it difficult to exactly find which are the questions because there are lots of thank you messages. From the next webinar onwards, okay, so we do respect all your feelings. Our thanks, sincere thanks to you for sending your thanks. Let's just keep this chat box only for posting, sharing your experiences or posting your questions. Dr. Anu, there are, I think, the next question that had come up, very interesting question. See, when you talked about doing multiple PDSA cycles, let's say if there is a PDSA 1 followed by 2, 3 and all. So the question is that, okay, when I finish PDSA 1 and I'm moving to the second PDSA, so do I continue doing PDSA 1 and move to PDSA 2, or so I stop PDSA 1 and then start doing the PDSA 2? That's the question.
Yeah, so a good question again. So when I was talking about plan, do, study, act, I had written 3 red words on the left top side of the slide, which was adopt, adapt, or abandon. Now, what is your learning from PDSA 1? So did the implementation of PDSA 1 improve the KMC duration? If I talk about KMC, the answer is yes. So I continue PDSA 1 and I top up or cream it up with PDSA 2. Why do I want to go back to my baseline? I will continue my PDSA 1. However, if my PDSA 1 had failed and ultimately I abandoned it, obviously my PDSA 2 becomes my next PDSA without the PDSA 1 working, because as a team, I understood that PDSA 1 did not work. So that is how you add PDSA 2 to PDSA 1 if you actually adopted or adapted PDSA 1. But if you abandoned PDSA 1, then obviously PDSA 2 comes in as the next PDSA cycle without the PDSA 1 in picture.
Thank you, Dr. Anu. And again, I think there's one more question which is more, again, it's relevant to the question we just discussed. So I think you also emphasized on the fourth component of POKI model, where we need to sustain the change. So people want to know, so what? How can we ensure that, okay, once this AQI project is over, how do we sustain the outcome after the project finishes?
Okay, so to sustain quality improvement, what we call as hardwiring, so there are multiple things in it. One thing is that you should be aware of the change ideas which actually led to success, number one. So you have to keep those change ideas in your pocket, and on the basis of that, you can actually develop a unit policy for that particular aim statement that you had carved. Second thing is, if you talk about context, so for kangaroo mother care, allow caregivers and parents to play an active role. Rope in the fathers, and you know that this is something which is going to stay forever. The third important thing is, make it a part of your daily clinical round or daily clinical work. Assign a team leader so that that project is ensured that that intervention is continued. You need regular reinforcement. You need, sometimes you might need some appreciation by the head of the department. You need to give recognition to the nursing champions, recognition to the residents who actually were responsible for the success of that particular QI project. But mind it, whatever quality improvement project works with systems is bound to stay, because you actually are using an approach to improve the efficiency of the system. You are trying to discard the waste. So these are small ways with the help of which we actually ensure that, yes, we can sustain a particular quality improvement project in the NIs.
Thank you, Dr. Anu. Again, Dr. Tenzin, thanks for the question. So he wants you to a little bit deal more. You talked about fishbone analysis, but I think the Pareto and all, you said that we'll be touching upon later. So his question is on, can you elaborate a little bit more on how do we select the tools for the problem analysis?
Okay, so there is nothing like a rule of thumb approach for saying that, yes, I would use only Pareto principle or I would use only 5 whys. You can use any tool that you wish to. Remember one thing, the last one, which is flow chart, is always used for a process. Process means, okay, so newborn being delivered and being transferred to the NICU, but baby is hypothermic. So it is a process. Delayed admissions, delayed discharges, these are processes. So for that, you prefer using something like a process flow chart. The third one, which I was telling that Pareto, I'll come to later. So Pareto actually comes from this person was an economist, and he said that 80% of the consequences, 80% of the outcomes are because of only 20% of the causes. That means that there is a highly unequal relationship between the input and the output. So that is why we call it the 80-20 rule. And to be very frank, this was derived from imbalance of land ownership in Italy, where he said that 80% of the land actually lies with only 20% of the people. Now, when we adapt it to healthcare, what do we say? We say that 80% of the problems are only because of 20% of the causes. Now, let me see. So if it is medication error, so there is a lot of error which is happening. There is a problem which is happening. So majority of the reason that this is happening is only because of 20% of the causes. One is because the resident's writing is awful, it is illegible. So we handle such problems, for example, transcription errors, prescription errors by Pareto principle. There is no rule of thumb that we need to use Pareto principle for a particular problem or 5 whys for another problem and the third one, the fishbone for another problem. That is not there. You just remember the process flow chart has to be for a process. Other tools you can mix and match. You might end up using all the 3 for different reasons. Sometimes you keep on asking why, and ultimately you need the answer of why. The last question answer is that because we don't have nurses. Now, you and I sitting here doing this webinar, we cannot solve this problem of not having nurses. So let us not use that tool. Use Pareto principle 80-20. Okay, so I am having a problem. I need to find out that the major reason is illegible handwriting of the doctors. Wonderful. My first PTSD cycle is that I'm going to ensure that all babies get a printed treatment summary or a printed discharge, and that takes care of a problem. So the reason we are using tools is to make our understanding easy. So don't get bogged down by whether I should be using 5 whys or Pareto or fishbone. Use anything that you like. Don't worry about which tool you're using, but use a tool to make your understanding better. That is important.
Thank you, Dr. Anu. There was a question on people wanted to know whether any online courses are available for learning the POCU in detail. Thanks to Praveen sir. Sir has shared the link here in the chat box for a free online POCU course. Dr. Anu, do you want to add more information on this?
No, that is fine. Even I wanted to say that. Thank you, sir. And this is an online POCU certificate course. In case you forget the link is also available on our POCU website. But workbook.poki.org is the link. Feel free to use it. In case there are any issues or you're not able to log in or there are some issues with logging in or username, feel free to text me. So I'm there in all your WhatsApp group, or you can contact Dr. Pratima in case the website has an issue. Otherwise, it's working well. We just checked it yesterday. A very good resource material, self-learning, and you need not more than 1.5 to 2 hours dedicated to complete and earn a certificate.
That's great. One more question. I think this question is from Chetan.
Chinmay Chetan.
Sorry?
Chinmay Chetan is asking.
Okay. It's okay. Chinmay Chetan. But I think many of us actually, we have whether it is students or nurses, I think statistics has been our Achilles heel, right? Whenever there is research, we are all worried about various tests that are being used. So what about the role of statistics when we do a QA project? Should we be worried too much about learning many tests related to statistics as far as a QA project is concerned?
He's particularly
Don't need to
asking
worry.
about,
Yes.
Anu, he's
Role of
particularly asking
statistics in QA policy.
about shifts, trends, and some values, some statistical values which you have to use for QI studies.
Okay, so that requires you to attend a hands-on workshop, but short of that, there are excellent videos on YouTube on shift trend. So it would not be right for me to actually explain it now. There are huge, wonderful videos on YouTube. But in addition to that, our POKI website also has a facilitator guide, which has a complete section on shift and trend, and you can actually read through that. The facilitator manual has a shift and trend discussion. So reading material is available on our website. And there are multiple videos on YouTube. That is the best way to actually, so if you want the exact page number from me, so open the POKI Facilitator Manual version 3 and it's on page number 174. Simple ways, it just needs you to learn how to plot data. So first is get your field right. So collect data in an appropriate way. Once you have the data numbers, then knowing what is shift, what is trend, and how to analyze it statistically is not difficult at all. It is on page number 124 of the Facilitator Manual available on our website.
Thank you, Dr. Anu. So maybe if I understand correct, can we say, see, we don't need to worry much about statistics when we say QA. Maybe all that we are interested is in choosing something which we want to address, quantifying it in terms of what we call as an indicator. And we're just going to see, we are going to bring in a change. And we need to follow that indicator over a period of time to see whether in which direction that indicator is moving over a period of time. Whether it is really going, if you want it to go up, it has to go up, or if you want it to come down, it has to come down. We already have a target. We have some timeline fixed. So just tracking your indicator over a period of time.
Yes.
Is a simple
If you
graph.
want to go in for a publication, some journals may ask you statistical significance of your result. For that, you would have to delve deep and do some personal reading, for which you can, I'll just send you the links on which you can learn more about it. So they are there in my slides also. So I'll share that. I'll be happy to share the details.
Thank you. We have covered questions posted in the chat box. So anyone wants to interact with Dr. Anu, you can raise your hand. So you can speak directly to Dr. Anu. Please raise your hand.
Vidhan, sir, are we going to make everybody unmute?
Dr. Anu, maybe we'll wait just for a few more minutes to see whether any more questions are coming up. So in the meantime, maybe just to keep the discussion flowing. So Dr. Anu, maybe whenever we say the word quality, so obviously people think of say the resources. So is it actually, so what are the relationship between quality and, if I have low resources, does it mean I have low quality, or is quality a problem only in a low resource setting, or is a quality is a problem everywhere, whether irrespective of it is a low resource setting or a high resource setting? What are the relationship between these two?
So there is no relationship between quality and resources. That is the first line. It is a problem both in our scenario, lower middle income country, and in high income country. It's only the desire to be willing to form a team, to do wishful thinking, to make a sincere effort. The intent has to be there. And obviously, some people have to be there to give you an intelligent direction and finally a skillful execution. So resources and QI, there is no relationship, neither inverse nor direct. That is what I can say as a single line. You may require resources after a particular while. When you actually are doing things on a large scale, you're talking about sustainability, but to kickstart, to learn from what effort your team is making, to understand database decision making, no, it doesn't require additional resources. Lakshmi wants to ask something. Her hand is raised in case she can be unmuted.
I've unmuted. Lakshmi, you can ask.
She's still shown us on mute. Somebody has to unmute Lakshmi Prasanna.
I said allowed to unmute. I did one. So Vidhan, if you can, who is the host, can do it. Or you can type Lakshmi. Vidhan is there. Pratima, Vidhan, anybody?
Yeah, sir. We can. She's in the panelist now. She can unmute and talk.
Okay. Lakshmi Prasanna, please unmute yourself. Please unmute.
Anyone else can. Lakshmi has done. Lakshmi is in the list. Lakshmi, you can unmute. Or there are so many panelists otherwise also. They can. Dr. Fazal, Dr. Arun Neoquip, Dr. Lakshman Sreshta, Dr. Sanjay Dev, anybody. Dr. Mala Kumar is there, Dr. Rakesh, Dr. Suman Rao, Pinaki, Bijan, Rakesh, okay. Dr. Bhashwati, Dr. Dheeraj. Mani.
So I think we have addressed most of the questions, sir. So Praveen sir, like to say.
Sir, I think Dr. Rakesh has his hand raised.
Who? Doctor? Ira? Kiska hath hai?
Dr. Rakesh. Dr. Rakesh.
Yes, sir, I want to say something.
Rakesh, please.
Yeah, good evening, ma'am. It was a very well presented webinar, and I happened to be learned the POKI workshop as TOT from you only. And we hope that the points are well taken by the state teams, and we as facilitators, we try to come up with projects which are suitable for our places where our people are working. And maybe we can give good projects from our state of Uttarakhand. That's all I want to say. Thank you, ma'am.
Rakesh is the secretary of NNF Uttarakhand.
Thank you, Anu. I think this was a wonderful presentation, very simplified, and you addressed most of the queries. I think although POKI course has been designed to be very simple and understandable, and we have seen people able to understand and execute, I still think we need to make it even more non-technical. Because when we talk to our, mentors, founding forefathers, Professor Bakhu, Professor Mehban Singh, we find they were exactly doing the same thing without using this technical jargon. So what is quality improvement? All we need to do is, first of all, as Anu said, identify the problem. And then develop a smart aim, and she described what is a smart aim. Now, it is also very important that all the team members are able to visualize this problem and the aim in the same way as you are. Because if that happens, then the resistance goes away. People talk, there's a question, if the boss does not agree. I mean, boss is like you only. Tomorrow you will be the boss. Why boss will not agree? Because, and it's not necessary what the problem which you are visualizing is actually a problem. So I think if everybody in the team is visualizing the same thing, then it becomes very simple. So once you have made a smart aim, as Anu said, how much to improve over how much time, then, as she said, you have to make a change. If you're going to continue the things in the same manner as you are, the result will not change. But the change cannot be a random change. It cannot be my or your whim or fancy. It has to be based on the system diagnosis. Like a patient of fever comes to you, if you start giving same treatment to every child, then obviously sometime it will succeed, sometime it will not. And to make the system diagnosis, Anu gave us few beautiful tools, whether it's the flow chart or it's the fishbone or the 5 whys. And based on that, you will find the reason why this particular problem is occurring. And then it's very simple. So once you found the reason why the problem is occurring, you change that process, but you test that through your PDSC cycle. Sometimes we may presume it's so obvious, if you do like this, things will improve. It's not always so. Like in our lives, we plan things, but things go haywire. So similarly, you have to do the test, and the only way you can test objectively, convincingly for everyone is to measure. And she told us for measuring, we need to collect data with a simple operational definition and tool. And once you have shown the measurement that things have improved, then it's very simple. Everyone is going to accept. So I think the principles of QI are very easy, very simple. And I don't actually particularly like when people say, we are trying our best, but my other members don't want to change. It's a behavior problem or it's an attitudinal problem. I don't think so. We should not aim to change people. We should aim to change the system. We are the same people when we go to Canada, USA, Singapore, we behave differently. Once we come back, we behave differently. Right? Because the system is different. Person has not changed. So my plea would be focus on system and not the people, and don't crib that people are not changing, people are not listening. Focus on the system, why people are working in a different manner. So I think this has been a wonderful seminar and discussion. And as Mangala said, why this webinar at the beginning? Because now when you attend the weekly sessions on particular topics, your mind is automatically trying to explore, okay, what I can improve and how I can improve in my setup. So that's the reason to have this webinar at the beginning. So nothing like this, great beginning. So thank you very much. Thank you. Over to you, Mangala. Surinder not audible.
Dr. Syed has been put in panelist because he has raised hands. Dr. Syed, please introduce yourself and speak if you can. Dr. Syed? Dr. Syed Asar. You can unmute. So 2 hands are there, Lakshmi and Syed, both are in panelist now. Dr. Syed, you can listen to me? Yeah. So, Bangla now.
Yeah, again, thanks to Dr. Anu again, and thanks to Praveen sir as well for very nicely summarizing the whole concept. So we all know that this is just the beginning. We just started yesterday, and we are just going to have lots of opportunities to discuss two specific issues, whatever topic is going on, as I just pointed out, in all the various improvisations or interventions, what we are going to learn in neonatal care. How do we really just apply those principles? What is happening right now in our unit? What can we do about it? How do we improve it in a systematic manner? That is an inherent part of this whole 6-week-long program. So that means all the participants will have lots and lots of opportunity to try to experiment with the QA principles. Obviously, we do have a lot of excellent teachers and mentors available in the group to handle you in doing that. And beyond, we are very sure that this will just be an initiation, and even beyond the 6 weeks, you will get into an auto mode of trying to plan your own QAs and start improving things and making the best tool out of this. So with this, I think that we do have again one more session on the same QA principle, because we have just described the principle. Dr. Anu already gave you an example of how a problem related to kangaroo mother care, improving kangaroo mother care, was tackled with POCI. You are all discussing mainly care of low birth weight newborns and the nutrition and feeding of LBW neonates. So in the next webinar, Dr. Deepak Chawla from Secretariat of Hospital Chandigarh, professor there. So he's going to tell us just how do we make use of this QA principle to improve the nutrition and feeding of low birth weight neonates. So let's just, we have just learned the tool. Now will be the next webinar is more getting into playing more with the tool, applying the tool more into the problem what you are focusing right now for this week, low birth weight nutrition and feeding. So we'll be back the next webinar with Dr. Deepak Chawla. I'm sure that you will have many more queries in the next webinar. Again, please, just again, a kind request again, please do away from thank you messages in the chat box. Please post your queries, and you are most welcome to share your experiences also. And we welcome more people to raise hands. We'll just look into whether there is any technical issue. I'm sorry, 2 people raised hands. I don't know. They were not able to share their thoughts today. We'll check the technical aspect also. We expect more people to come forward and interact and express your view. It need not always be a question. Please come forward to express your views and experiences, share your experience also for the benefit of the whole. Sir, shall we call it a close it?
Yes, ma'am. Thank you. Thank you.
Thanks, everyone. It's a fantastic learning experience today. We'll keep learning. See you all tomorrow. Be there in the WhatsApp groups. Good night.
Thank you. Bye-bye. Good night. Good night.
Thank you,
Thank you.
Mangla,
Good night.
Ira, Anu, everybody.
Thank you. Thank you, sir.
Thank you, sir.
Thank you, everyone. Good night.